Greetings from Mahalingam, TwinTech Academy, Chennai. I warmly welcome all the delegates, speakers, and chief guests for a webinar on community eye care, challenges and solutions. On this happy note, I would like to welcome all our speakers, Dr. Rishi Borah, Country Director, Orbis International, to accept our invite to be the chief guest of this webinar and deliver his inaugural speech. I welcome Dr. Kaushik Murali, President and Medical Director of Sankara Eye Foundation, Bangalore, to talk on cataract screening. I welcome Dr. R. Krishna Kumar, Senior Optometrist and former Principal, Elite School of Optometry, Sankara, Nethralaya, to talk on refractive error screening. I welcome Dr. A. Rajiv, Senior Optometrist, Research and from the Department of Glaucoma, Sankara, Nethralaya, to talk on glaucoma services and screening. I also warmly welcome Dr. Rishi, Head of the Department of Binocular Vision, to talk on binocular vision and amblyopia screening in this webinar. I warmly welcome Dr. R. Rajiv Raman, Senior Consultant, Sankara, Nethralaya, Vitreoretinal Services, to talk on diabetic retinopathy screening process. I warmly special welcome to Dr. Abiola to accept our last minute invite to talk on community-based rehabilitation. She is a head of the Department of Rehabilitation Center at Prasad Eye Institute, Hyderabad. Once again, I warmly welcome all the delegates, speakers, chief guests for the webinar. On this juncture, I would like to briefly introduce about TwinTech Academy. TwinTech Academy is a unit of TwinTech Academy Business Management Solutions. It is a company engaged in offering practical and implementable solutions in the area of health education, management training, management consultancy, and counseling. TwinTech Academy is supported by many eminent practicing professionals as a member of the advisory board. TwinTech also offers solutions and services in other sectors too. Happy to note that so far TwinTech Academy conducted over 250 training program in healthcare. It includes for healthcare management, healthcare training, optometry services, and etc. And conducted over 10 healthcare projects. So on this happy note, I given the responsibility to Dr. R. Krishna Kumar to moderate the session, and he also talking on refractive error screening in this important webinar on community eye care, challenges and solutions. Over to Dr. Krishna Kumar for this further proceedings. Thank you all.
Thank you, Mahalingam. And as you all know, the backbone of such initiatives is Mahalingam. Thank you, Mahalingam, for inviting all of us to be part of this wonderful, important topic and on community eye care challenges and solutions. And we have amidst of us the eminent and most loved person as chief guest, Dr. Rishi Borah, Country Director, Orbis India, and also other eminent speakers as told by Mr. Mahalingam. And they are going to share with us their experience in various aspects of eye care, especially in outreach initiatives. We all know that the impact of our community care still needs to achieve its goalpost. In this session, the eminent speakers will be enlightening us with the challenges which they have come across and the solutions which are awaiting for all of us to really implement it in future. So with this few words about the CME, I would like to take the pressure of introducing today's chief guest, Dr. Rishi Borah. Rishi joined Orbis 13 years ago and has advanced to a progressively more responsible position. Today, he is the country director of Orbis International, leading Orbis programs in India, Indonesia, and Nepal. Over the years, Dr. Rishi has developed innovative, impactful, and sustainable homegrown eye care initiative. I am the witness to one such program with 6 different institutes, including Nethralaya, and REACH initiative of trying to cater to millions of people, especially in children, communities across India. And also, I understand this same initiative is trying to extend to Nepal. And before Orbis, he worked with UNICEF and CODIDE, and he is a committed and enormous part of his life to help ensure that children across the country have a better life. It is a great privilege for us to have you here, Dr. Rishi Borah, and also love to listen to your enlightening talk as a chief guest of this wonderful CME. Dr. Rishi Borah, yours. You can share your.
Thank you, Dr. Krishna Kumar. Let me share my screen. I'm sure. Can you hear me?
Yeah.
Okay. So thank you. First of all, I'd like to congratulate TwinTech Academy for organizing this very important webinar on community eye care at a very relevant time. And I'd like to also thank Mahalingam sir, Dr. Krishna Kumar, and then Dr. Rizwana, allowing Orbis to be part of this great webinar and initiative. I think this is very important and then very close to Orbis' work, this community eye care for last so many years. And then I think all of us, we're from the eye care fraternity, need not too much of introduction about what is community eye care, because all of us, we have been doing it for a very long time. And I'd like to start with like this country is the first country, I think, to start a nationwide program called National Program for Control of Blindness in 1976, with a very nice flagship quote is like eye clinics at your doorstep. It was the slogan when we started this program way back. So we have this community ophthalmology thoughts from a very old time in India, and then many of the replicable successful model of community eye care has been developed within this country, and then this experience has been shared with the rest of the world in terms of reaching out to community for eye health. So briefly, last 20 years, whatever Orbis has achieved and then what experience we have through community eye care. A couple of points I'd like to reiterate in terms of community eye care that taught us that this eye care service is delivery targeted at all age group, and then it involves both primary and then secondary level care. Community care in the past often synonymous with outreach camps. However, this is a realization that now community eye care broadly covers availability, accessibility, awareness, affordability, leads to accessibility of eye care services through various initiatives and eye care delivery models. I think I'd like to also mention about the recent World Report on Vision, a very nice quote from them, and then which is also for all of us working in the community eye care sphere. I think need to carefully look at this statement. The global needs for eye care is projected to increase dramatically in coming decades, posing a considerable challenge to health systems. So currently, whatever systems we have and then however we are providing community eye care really need to be looked at in order to take this particular statement seriously. I think really among those 5 important actions in World Report on Vision, they recommends that making eye care an integral part of universal eye health coverage to address the challenges arising out of changing demographics, inequity in access, and then lack of integration. A package of eye care intervention is needed to facilitate the integration of eye care into the health sector and universal health coverage to effectively meet population needs. And then ensuring, this is also important, third point about ensuring financial health protection and avoiding catastrophic expenditure on the part of the users. With that, I think there are a lot, as I said, mentioned earlier, that there are a lot of successful replicable models of community eye care we have developed over so many years. There are a few of them I'd like to mention. It is not like that there are other institutions are not innovatively providing care to the community, but these are the worth mentioning. And then these models are replicated not only in India, the other countries as well. So the key highlight of this Arvind Eye Care community model is use of this tele-ophthalmology, bringing that ophthalmic consultation towards community or at the doorstep of the community. Is a very innovative way of making ophthalmic consultation available to the community. Where ophthalmologists are not available, and we know that there are scarce number of ophthalmologists for providing eye care across the country. So I think these technology-driven initiative, what Arvind has initiated earlier, I think has reached out to many more corners of the country where eye care needs are there. So apart from that, I think probably one more important thing they brought in identifying so women from the villages and then trained them in eye care, delivering eye care, and they're providing care to the community. It's more of a kind of engaging community to provide their eye care at the doorstep. Is one key. There's a few key points about the Arvind Eye Care community eye care model. LV Prasad Eye Institute created this bottom-up eye care pyramid, which starts from a vision guardian connected to a vision center. Vision center is connected to a secondary level center. Secondary level center connected to a tertiary and then center of excellences. The eye health system through this particular pyramid has been accepted by many countries, apart from many institutions within India. RP Center for Ophthalmic Sciences also created eye clinics for the urban slums in NCR. Normally we feel that urban area, the human resource for eye health and then infrastructure for eye health is available everywhere, but still there are many pockets where urban slums basically not getting access to eye health services. That is innovatively putting all these clinics in the urban slums to provide eye care services to the underserved. Shankar Nethralaya, being all the school eye health program and other community eye care initiative, one of the key things that have been brought into the community eye care bucket is the occupational eye care needs. And the various unorganized sectors eye care needs being addressed through the Sankara Nethralaya's model of community eye care. To talk about my organization, Orbis has been working in India for a long time. I think we are known for our flying air hospital, which is the world only teaching flying air hospital. Flying hospital. So this hospital landed in 1988. From 1988 to 2000, we have been conducting a lot of flying air hospital program to train people, not only ophthalmologists, but other paramedical or para-ophthalmic personnel also were trained in these programs. But in 2000, we realized that not only transferring and then building skills is not going to be enough. If we do not create an environment for the trained people to practice their skills. So with that thought, we started the Orbis India office in 2000. And from 2000 onwards, we create a program called India Childhood Blindness Initiative. This is a flagship program with an intention to establish children's eye care center across India. So till now, we have established 33 children's eye care centers across 17 states. And key point that I would like to highlight about this particular program is bringing that concept of pediatric ophthalmology team. Ophthalmology is the key to providing care, but at the same time, for effective and efficient care, you need to have a team around the ophthalmologist. So I think probably this bringing pediatric optometry, pediatric nursing, pediatric anesthesia, pediatric counseling, or pediatric outreach team. So these are the people who are combined together, created this particular concept called pediatric ophthalmology team. That was initiated through this particular program, and that has shown a tremendous amount of result over the last 20 years. We created this 6 years childhood blindness approach, where earlier we used to have only service delivery program for 4 years, but over the period of time we realized that the quality of services can only be ensured if the institutionally quality is built. So this 2 years we do work with partners to build a QMS, quality management system, and then start pediatric ophthalmology service delivery projects. So that's how this quality also bring into the delivery area of Orbis work. The 3-year school eye health program that Dr. Krishna Kumar has mentioned about this particular program. We started this, we call it as Refractive Error Among Children REACH program. That is also to reach out to kids in the schools who basically have refractive error, but otherwise also other problems get identified, and then they're being referred to the tertiary level and institution. And those cases who can be dealt with the community, referred back to the vision center, and they were taken care of. So after that, I think in the primary eye care, one key thing that we had done in last 3 years, creating a concept called Green Vision Center, because these 33 institutions that we work with, when we build their capacity for outreach initiatives to identify kids at an early stage, one of the key things that we identified that all the vision centers that we supported, our partner institutions sometimes find it difficult to continue the services because of electricity, and electricity supply is not that continuous. And then all of our equipment in the vision center, most of them, they run on electricity. So if you do not have electricity for some point of time, just that particular time period, the services are stopped. And then sometimes people, people who are having eye problems stepping into the vision center could not get access to the services because of this non-electricity supply, or electricity is not available during that time. So once they go back, I think they get into so much of work, in their place. Sometimes getting those patients back to the vision center was getting difficult. So what we thought that what we can do to actually ensure this continuity of electricity, and at the same time responsibly consuming electricity through vision centers, we created this Green Vision Center concept. This Green Vision Center basically runs on solar energy, and we use a software called ICOM, which takes care of the data management with the Vision Center. You don't have to use papers there. And then I think lights and fans and things like that we use in the Vision Center, all are first 5-star rating, so power consumption is less. So that's how this particular concept we are implemented as a pilot in with one of our partner in West Bengal. So I think that given a lot of dividend in terms of continuum of care at the primary level. So I think probably this is one of the areas that we are going to focus on and try to strengthen or expand these services to other areas too. So now coming back to the challenge we collectively face, this accessibility of care to all, lack of facilities in the community, most centers in the urban areas, a lack of trained eye care professionals and necessary infrastructure in the underserved area in the major is one of the major barriers to provision eye care services in our country. Disparity in available human resources in rural setups, most of the medical professionals are in urban areas, and a lack of awareness on eye care and availability of services are major challenges that we collectively face while providing primary eye care. But this Vision 2020, I'd like to show this slide also. The year 2020 is crucial for all of us in the eye care community. The Vision 2020 global initiative has aimed to bring the eye care community together to bring about initiative for preventable blindness in order to eliminate avoidable blindness by 2020. Given this background, basically this is a time for us to reflect and then assess not just status of the eye care in the country. I think probably what should be our way forward, keeping the challenges ahead in mind. So when I think about this slide in a way forward, I thought of the new what Dr. Krishna Kumar has referred to, the REACH program that recently we have concluded. It was a 3-year program with 6 partners in 15 districts. We have implemented for 3 years, and we reached out to more than 5 million kids. It was a pretty big initiative we undertook. And then this particular initiative has actually given us a lot of insight. One of the things that last 20 years we have been doing in our children's eye care program, I mean, so many other program also, we have seen that now the moment this pair of spectacle is given, the program responsibilities gets over. Means from the provider perspective, maybe we had done well. Means we have given spectacles to kids, and they're with an assumption that they're going to wear, and then the refractive error problem is going to be resolved for school-going kids. But when we implemented REACH and then try to look at that, now what is the outcome of this particular intervention, whether all the kids are wearing spectacles or not. If they're not wearing spectacles, what are the reasons, and then how we can resolve as a provider, how we can resolve that issue also to ensure that no child, whoever is given spectacles to a child, the child is wearing spectacle and then getting benefit out of the pair of spectacle. And then at least address the refractive error in them and giving them an opportunity to have a clear vision. Probably that program gives us a big insight that it was started with a 28% of compliance, what we have given, and then due to all these different initiatives that we are putting in place, that from the providers to the child's perspective, when that got changed, I think from 28% it jumped up to overall 60% of spectacle compliance. So that gave us an idea that that actually reiterates what World Report on Vision has said, that to integrate people-centered eye care. Earlier it was provider center, or we provide the spectacles and then we leave it onto the child to figure out that whether they're going to use it or not. But I think really when we try to figure out our outcome of the pair of spectacles, that's where there are a lot of things came in that now it is a little loose. If the fitting is not good, even if power is perfectly fine, the child is not going to wear the spectacle, and then we are not going to provide the maximum benefit for the child with that pair of spectacles. So I think this shift from the provider to the child centric refractive error program, that we gained this experience very clearly, and then we thought that this has to be incorporated in our future programs, that not only a pair of spectacle, and how we can make the child wear the spectacle, that is going to be will be important. Means earlier the pair of spectacles given by us without any choice given to the child to see that what kind of color, what kind of shape of spectacle frame they want. That choice was not there. So I think in this program we try to give this right to the child to choose their own spectacle. So that also have actually helped this improvement of compliance in the program. So there are many such points where there which actually triggered us that no, this is not only pair of spectacle. I think beyond, when you give a pair of spectacle, that your community work starts. I think until unless the pair of spectacle provide enough benefit to the kids, I think probably we will not be able to justify our programs or community eye care initiatives. The second thing we thought that related to that particular program, when we identify somebody and then refer them to the hospital for a pair of spectacle, it is very easy for us to refer them to the hospital, but it is very difficult for the child and then parents to take out those 1 or 2 days going to the hospital and then get the spectacle from there. Cost will be other factor that they're going to lose out the wages, and then I think probably taking out that particular day to go to hospital and then just collect and then have the spectacle done from the hospital. I think probably creating in this program only we created vision centers around, which has shown that probably that is also one of the reasons why from 28% to 60% improvement in compliance to that is spectacle compliance, and then their referral compliance also actually around 30%, and then it is improved to not 60%, I think around 50% was improved. That improvement also because of actually creating those facilities, and then even if existing facilities are also strengthened for providing say refractive error services or pair of glasses for the kids. So that way, this is also one thing that was reiterated in our mind, that this having more fixed facility is the way forward to remote for the remote and then underserved areas to provide eye care in a best possible way to the community. The provision of training, I think whenever I'm again going to refer back to this particular program. When we delivered this program, we saw that there are various little kids from first standard to say 12th standard we screen. So it is easy for the elder group of kids to do screening and then identify them. The little ones, it is very difficult to handle while we are doing screening. It might be a very experienced person to do the screening. I think probably handling a smaller kid also needs a little bit of skills. I think those trainings and things like that needs to be in domain in order to provide required support to the person who is doing screening. So provision of training also will be a very important thing. And then community engagement, I think community engagement point, if you look at...
Sorry, Doctor, can you explain the process? Sorry. Can you speed up the...
Yes. So this is like community engagement is one part, and then I think technology assisted service delivery also, for data management point of view, we need to be very, very careful, because without data, I think taking a decision in terms of course correction is very difficult. Advocacy and awareness also one of the area that needs to be taken care of. Last slide is about the community of optometry has been one of the key focus for Orbis in our all work in last 20 years. In the team I was talking about, one of the key responsibilities offered through optometry, I think pediatric optometry has been enormously successful for providing pediatric eye care to through children's eye care centers. And I think in REACH program, is without I think optometry fraternity, we would not have done, successfully done this particular program across 15 states. So your responsibility in future, bringing this community eye care to the closer to the community will be very, very crucial. And I'd like to conclude my lecture saying that now all of us a big task ahead, but together we'll be able to achieve whatever needs to be done for the community in terms of eye care. Thank you. I'm sorry that